Good evening, everyone present here. I am Faraz from IJCP Group. Welcome all the participants on today's webinar. Let's welcome today's speaker with great honor, none other than Professor Dr. Shobha K. Ma'am. And let me share some of the achievement of ma'am. Ma'am has done MBBS, MS in Obs and Gynae, MCS Surgical Oncology, Professor and HOD of Gynae Oncology, KMIO, and President KSC AGOI. And today, ma'am is going to discuss on a topic, very important topic, and which should be known to everyone. And the topic is breast cancer and fertility preservation, Breast Cancer Awareness Month. To know more about this topic, I would like to invite ma'am and hand over this session to ma'am. Ma'am, stage is yours. You can proceed from here.
Thank you, Faraz. Thank you for the warm welcome. Yeah, this month is Breast Cancer Awareness Month, but nevertheless, breast cancer is the number one cancer affecting Indian women. So I think not only in the month of October, we should be aware of this cancer throughout the year. So previously, breast cancer was number 2 and number 3, but now the incidence has rose. It is surpassed cervical cancer also. So breast cancer was affecting postmenopausal age group previously, but now the trend is changing. Though there is an increasing trend in the incidence, also we have seen the incidence of breast cancer raising in younger females. Younger females meaning in the reproductive age group. So we do see females diagnosed with breast cancer in the age group of 35 to 45 very commonly. So the incidence of breast cancer is about 36 per 1 lakh population, we say. In that, about I think we can take around 30% of them fall in the category of below 40 years of age. So it's definitely very difficult to treat young patients with breast cancer. And also nowadays the trend of educated females are raising, and the late marriages concept is in. Late conceptions are followed by many females. So we do see many of the females, infertile females, getting diagnosed and getting the treatment of breast cancer. So what do we do in these kind of patients? Here, this topic is relevant because it's important to navigate the treatment and also plan appropriate future family for them. Yeah. Breast cancer is the leading cancer affecting Indian women. Median age group is 55 to 65. As the age increases, the incidence of breast cancer also increases. But we do see 20 to 30% of them following less than diagnosed in below 40 years of age. So, but breast cancer in young females is definitely more aggressive in nature. How the trend is going on, we're seeing it is more aggressive. More incidence of triple negative breast cancers are diagnosed. So we have to be cautious in treating them. What is fertility preservation? It is defined as the use of available technologies to help patients retain their fertility or ability to procreate. It is a fundamental issue for women whose future fertility might be compromised, as reproductive capacity may be seriously affected by the age. Means they're getting treated at the age of 30, 35 years. So even the fertility keeps decreasing as the age progresses. Or if they are affected with younger patients, so genetic syndrome positivity will be very high. And also the treatment will be giving are gonadotoxic. So we have to look into all of this aspect. So chemotherapy is one of the part of multimodality treatment of breast cancer. So we do have gonadotoxic chemotherapeutic agents, but the intensity of the toxicity varies. So the high gonadotoxic chemotherapeutic agents are cyclophosphamide and ifosfamide. So cyclophosphamide is commonly used. Then moderate gonadotoxic are platinum drugs like cisplatin, carboplatin, and then doxorubicin, etoposide. So these drugs also are commonly used in young women. The milder ones are bleomycin, actinomycin D, vincristine, methotrexate 5-FU, which are usually used in ovarian cancers and especially GT and germ cell tumors, etc. So, what is the impact of the breast cancer treatment on fertility? Chemotherapy can damage the ovaries, especially the follicles, and lead to infertility or premature ovarian failure, that is, early menopause. Radiation, if necessary, when patient takes pelvic radiation, it can affect the pelvic organs in some cases, not all cases, some cases, especially the uterus and vagina, causing severe fibrosis and sexual dysfunction. And if ovaries are fallen into the field of radiation, then definitely the ovarian function also is damaged, hampered. Surgery, when we do surgery for breast cancer, it indirectly can lead to psychological stress, especially when we do mastectomy. So that also should be taken into consideration. Gonadal failure affects the hormonal function and sexual function both. So more than 80% of the survivors can have long-term effects of cancer treatment on fertility. So you can see how much of the burden is, right? So what about the delayed childbearing? As I said, most of the females are, conceiving later in their age. So we are seeing many of them, the first pregnancy being happening at the age of 35, 36, around 40 years. It is quite common in a well-educated and working women. So what happens to the fertility? It decreases gradually after 32 years, but faster after 37 years. So the fertility preserving methods, whatever we do, the success of that will be reduced if the female progresses in her age. So when childbearing is delayed, it compromises the fertility. Serum FSH, AMH, usually these levels are done prior to the chemotherapy, which will assist in selection of gonadotropic doses and prognosticate the gonadotoxic side effects also of the chemotherapy. Oncofertility is the emerging field now. So this brings together oncologists and fertility specialists, and hopes to provide real options to young population who undergo life-preserving but fertility-threatening treatment of cancers like chemotherapy, especially chemotherapy, and radiation in some. So what are the fertility preservation options? So always address the possibility of infertility before the treatment starts. So you have to direct them to appropriate fertility specialists, give the whole range of this fertility preservation option, counsel the patient along with the spouse always. And also along with this, psychologist counseling also is very much needed, because there is also emotional distressing condition the females will have. So we'll need a psychosocial counseling also. So chemotherapy, as we know, both CT and RT leads to ovarian gonadal dysfunction, and definitely before the treatment starts, we have to give all this option. So what are the fertility preservation options? We have cryopreservation of unfertilized oocyte, embryo cryopreservation, ovarian suppression, ovarian tissue cryopreservation and transplantation, conservative medical management in some, and conservative gynec surgeries if a gynec cancer is diagnosed. So what is cryopreservation of unfertilized oocyte? These are offered for patients who have no male partners, or who do not wish to use donor sperm, or who have religious or ethical objections to embryo freezing. Second option is embryo freezing. This is the most commonly recommended one and the most established assisted reproductive technique. So here what we do ovarian stimulation with gonadotropins, then surgical oocyte retrieval is done, then in vitro fertilization of the oocyte and sperm in a lab dish, followed by freezing of all the embryos. Then this survival of the thawed embryos are about 90%. Implantation rate is up to 30%, but when you take cumulative pregnancy rate is about 60%. Here there is need of donor sperms, so that proper counseling is very much required, and consent of the patient. Need of IVF is there, but this procedure is unacceptable if estrogen sensitive tumors are there, because a lot of estrogen stimulating tumors will be there, and the cancer keeps growing there. Next is ovarian tissue freezing. It is recommended for patients unable to delay the cancer treatment for ovarian stimulation. So ovarian stimulation will take 3 to 4 weeks. So whenever there is we do not want to delay the cancer treatment, ovarian tissue freezing can be recommended. Mainly for pediatric patients, these are recommended, and in hormone dependent diseases. So reimplantation, so their ovarian tissue are taken, and then reimplantation of this tissue is done either in pelvis, which is done laparoscopically, or elsewhere, that is heterotropic or autotropic, we say. Autotropic is when we put into the pelvis, heterotropic when somewhere else we put. It has a potential of restoring the fertility and ovarian function secretion. Next is ovarian suppression. So this also is gaining popularity now. Here we use gonadotropic releasing hormone agonists during chemotherapy, which can protect the ovarian function. So all throughout chemotherapy, we suppress the ovaries by giving them GnRH agonists. So two meta-analyses have shown that it reduces the risk of premature ovarian failure. The next is ovarian transposition. So whenever there is a requirement of radiation to the pelvis, we do this ovarian transposition. Either laparoscopically, it's best done. So here we move out the ovaries out of the field of radiation. So we take the ovaries and fix it high up the pelvic brim. So when is the timing of the fertility? So best time is to start before the treatment, before either chemotherapy or radiotherapy. During the treatment, it's limited options because the effect of chemotherapy would have started. After the treatment, it is potential to assess the ovarian function and fertility options post-therapy. So post-complete treatment, we assess the ovarian function again. So not to forget the psychological concern. Emotional and psychological consideration also should be equally addressed. Pre-diagnosis, from the time the patient walks in the OPD with the complaint, during the evaluation of that, during the biopsy, either be it biopsy, post-biopsy, once diagnosis happens, post-diagnosis counseling, and pre-treatment counseling, during the treatment, post-treatment, in all settings, the psychological, emotional conditions should be taken into consideration, and a clinical psychologist should be taken for counseling sessions. So we have to tell her the impact of the cancer on her desire for motherhood. Totally well explained, along with the spouse. Then also next you have to tell her the safety of pregnancy after the treatment. It should be always weighed whether it is completely safe or there will be some side effects of the treatment or not, should be explained in detail to her. So balancing the treatment of cancer without compromising with the principles of oncology is very important, and then balance it with the future family planning. So to conclude, as breast cancer is increasing in young women, the need for fertility preservation is emerging. But as I said, though it is a priority, but it should not be at the cost of compromising the optimal cancer treatment. So gonadotoxicity should be kept in mind, and advise whatever we recommend, we should tell them what effect it has got on her fertility. So if the chemotherapy drugs giving is highly gonadotoxic, the consent, it should be explained, consent should be taken. Then if it's high, then before starting chemotherapy, the fertility preserving options should be given. So either go for embryo cryopreservation or whatever patient opts. So put her to a fertility specialist, and then because a lot of cost also is involved in this, it should be not financially burden also, and the success of that should be explained in detail, and then with the proper informed consent, further things should be taken for therapy. Thank you.
Thank you so much, ma'am, for taking out your valuable time and sharing your knowledge on this topic, ma'am. I definitely think this session knowledge is going to help all the participants who have joined this session. And we have received some question, ma'am. With all your
Okay.
permission, shall we take these questions?
Sure, sure.
And I can see the first question is from Dr. Snehali, and she's asking, how does cancer treatment affects a woman fertility, ma'am? What's your point of
Yeah.
view on that?
So here, see, breast cancer is a multimodality treatment. Especially in young patients, we go in for breast conservative surgery. So whenever breast conservative surgery is there, we'll have to give chemotherapy and radiotherapy is a must, right? So whenever chemotherapy is given, it is these chemotherapeutic agents are gonadotoxic. So it affects the ovaries, ovarian function. So there will be this whatever follicles she will be developing every month that will be stopped. That function will be stopped, or it can harm the eggs or the follicles produced. And then repeated this many cycles we give chemotherapy. So she can go in for premature ovarian failure also. So we have seen that they go in for premature ovarian failure. So she goes in for early menopause. So definitely, if she's an nulliparous lady, she will have problem in conceiving, in becoming pregnant post treatment, or if at all if she has kids. But she can, if she has, I mean, with all this treatment, if she goes for early menopause, then she will have other problems, like it could be osteoporosis, it could be like what is that, cardiac, so whatever that the hormones are giving, protecting us, bone health is gone, and your cardiac protection also will be gone. So
Yes,
again,
ma'am.
patients are more prone for osteoporosis and cardiac events and thrombo events. So
Yes,
that
ma'am.
benefit is gone.
Thank you so much, ma'am, for answering this question. Moving forward, we have another question from Dr. Uh, Nishu Priya, and she's asking what are the risks of chemotherapy, radiation therapy, and hormonal therapy on ovarian reserve and reproductive potential, ma'am?
Yeah, as I said, I gave you the list of chemotherapy which are gonadotoxic. So, highly gonadotoxic are cyclophosphamide and ifosfamide. So, if they are used, especially we used in ovarian cancers, in breast cancers, usually adriamycin is used. Those are mild to moderate gonadotoxic. Depending on the dose, how much of dose we are using, it can affect the ovaries on that matter. And then radiation, in the breast cancer, usually radiation is given in the breast field, so usually it does not affect the ovarian function. But if it is a endometrial cancer, or ovarian cancer, where there is requirement of pelvic radiation, then ovaries can be affected with radiation. So and also, if uterus is affected, it can cause fibrosis in the muscle of the uterus, it can cause fibrosis in the vagina, and that will again, the patient will have sexual dysfunction. So that is how young patients can become psychologically depressed, and they're going for severe depression because they're young patients, and the family will be totally distressed.
Yes, ma'am. Thank you so much, ma'am, for answering this question. We will be taking one last question from today's session from Dr. Subramaniam. He is asking what are the success rate of fertility preservation procedure when performed before chemotherapy or surgery?
Yeah, see, before surgery, when we do surgery, as such, do not affect the ovarian function, especially the breast surgeries. Only psychologically she be affected. But chemotherapy is the one which affects the ovaries. So before starting chemotherapy, usually we start chemotherapy post surgery, 3 to 4 weeks, anytime post surgery, after 2 weeks. So this is the time where we have to make use of the fertility preservation option. So if you start chemotherapy, definitely there will be some effects getting started on the ovaries. So before starting chemotherapy, so send her to a fertility specialist. Then you ask her for this embryo cryopreservation. Or nowadays we have this suppression, ovarian suppression, which we are using GnRH agonists. So all medical oncologists, surgeons, also before starting chemotherapy, they are using GnRH agonists. So either weekly, sorry, monthly, or once in 3 months, they're giving the lesuride or those kind of GnRH agonists, and then suppressing the ovarian function until the chemotherapy finishes.
Thank you so much, ma'am. You have explained each of the questions really well. I hope I can see, ma'am, there is no more question from the participant. I hope you have done justice to this topic. I hope that all the audience are understandable and got the points clear. And like, ma'am, as we don't have no more question, ma'am. With all your permission, shall we conclude this session for
Yeah, yeah.
today?
Thank
Thank
you
you.
so much for
Yeah,
providing
ma'am.
this.
We would like to see you in future also with different topic. Till then, take care of yourself, ma'am. Have a
Thank
great
you.
day.
Bye. Good
Thank you.
evening.
Bye, ma'am.